diagnosis of opioid use disorder is pretty straightforward. It's the same criteria as any substance use disorder. And I think that's the easy part. But then getting someone onto Suboxone is the tricky part. And we can talk a little bit about how to do that more easily and which approach might be appropriate for an individual patient. So, I always want to talk to the patient about, their past experience with Suboxone. A lot of people will have already tried Suboxone, whether it was, from a friend or they've already been in a program, in which case they kind of know the drill and they know how they want to get on it. And I often find people that have very little, fear of going through a little bit of a withdrawal period from their illicit fentanyl or heroin, what have you, and just starting the Suboxone after a brief withdrawal period. Other people have precipitated withdrawal when they have started the Suboxone too soon after illicit use and have had a terrible experience and are very scared of precipitating withdrawal, in which case a microdose approach would make more sense. So the approach that you take should honor people's past lived experience and be a shared decision-making process that's designed to set the patient up for the most success in stabilizing on a steady Suboxone dose. And just as a reminder, the key goal of the Suboxone is to break that cycle of illicit use and withdrawal and hustling or what have you in order to use again, so that people can focus on other priorities in their lives, whether it be housing or jobs or rebuilding relationships. And the Suboxone does an incredible job that way of mitigating the psychosocial disarray that comes with opioid use disorder. And it also prevents overdose, right? Because it's much safer. It has a respiratory depression ceiling. And with, over 70,000 people dying of a opioid overdose in the last year, that should certainly be at the top of our priorities. So an example patient for microdosing, typically these are folks who are going to be a little bit more psychosocially stable. I think the classic example would be a patient who has been on chronic medically prescribed opioids for a long time, but they're they're having withdrawal symptoms, they have tolerance, they may be showing aberrant behavior, taking more than prescribed. They may be elderly and really scared of having any kind of precipitated withdrawal whatsoever. These are often your chronic pain patients. And in this case, these folks are often able to follow instructions pretty carefully and adhere to the microdosing regimen, which I think we've gone over in past echoes. But it's a little bit complicated. It involves cutting strips and it plays out over the course of several days, which can be agony for some people, but for the people that again really want to prevent any withdrawal symptoms or precipitated withdrawal, this is the way to go. With that said, I want to focus on the macrodose approach today. So I really would like to acknowledge Terry Waters, who's on the call today. She does amazing work up in Espanola. I used to work up there in a similar capacity. And, a lot of and not to stigmatize Espanola whatsoever, it's a community that is very near and dear to my heart. But the population we worked with up there, specifically at the syringe exchange, did struggle with homelessness, in often cases, polysubstance abuse, including meth, which provokes psychosis and makes people fairly disorganized, and then also high rates of concurrent severe mental illness. So as you can imagine, this could be a population which has difficulty adhering to a complicated microdose induction. This is also a population which may not have a steady steady access to their opioid of choice, fentanyl, for example. And so they periodically go through pretty significant withdrawal before they're able to procure fentanyl again and use it again. So they're not a stranger to that withdrawal, and they may not be as afraid of it, or at least more accustomed to it than the previous example of an elderly chronic pain patient on oxycodone. And these are also people that may have, as a stopgap, used illicitly procured Suboxone in the past, so they kind of know the ropes, and they've been on it before, and they kind of are a little more familiar with and have a higher tolerance for the risk of precipitated withdrawal and just the withdrawal itself. And for this population, I really find that the rip off the Band-Aid macrodose approach works better, because when people come in the door, they have kind of a moment, a reachable moment. They're ready to stop the illicit opioids, and this could be a small window. And I really feel like you need to strike while the iron's hot and get people up onto a macro dose of the buprenorphine or the Suboxone as quickly as possible. So again, you can break that cycle of use and withdrawal as soon as possible and aggressively. This is particularly important in the day and age of fentanyl, which has largely replaced heroin in the illicit opioid market, because fentanyl has such a high binding affinity and such high receptor activation. It's very potent, and therefore often requires very high doses of or relatively high doses of buprenorphine in order to saturate the receptor and ameliorate and satisfy cravings. But again, just to drive home the point that this should be a shared decision-making process that's tailored to the goals and the desires of the patient. So once you have that shared decision-making conversation, you've settled on a macro dose approach. How do you do it? So with fentanyl or other short-acting opioids, such as heroin, but not methadone, for example, you're going to want to wait about 12 to 24 hours out from the last illicit use for short-acting opioids before a patient is going to be ready to start their buprenorphine or Suboxone. And again, back to basics, they must be in sufficient withdrawal to start it to avoid precipitating withdrawal. Although there could still be a little bit of precipitated withdrawal, and we'll talk about that. You can give a person a subjective opiate withdrawal scale, but this is not always foolproof. And I typically tell people that if it has been at least 12 hours, as I mentioned, and they're experiencing GI symptoms such as nausea, vomiting, diarrhea, they're ready. And to be extra safe, you can instruct them to cut a tiny corner off the 8 milligram Suboxone strip and place it under their tongue to judge their readiness. And if they don't feel worse, or they feel about the same, or they even feel better, then they're ready to go, full bore and take the whole strip. And at that point, they'll start with an 8 milligram strip sublingually, and then they'll wait about 2 hours. I recommend 2 hours because it takes about that much time for the sublingual buprenorphine to reach peak blood concentration. And if they're still having cravings and withdrawal, they can take a second 8 milligram strip at that time, and then wait another 2 hours. And if they're still having cravings or withdrawal symptoms, they can take a third strip up to a maximum of 24 on that first day. And whatever they take on that first day, and it satisfies their cravings, that becomes the dose that their daily dose that they take moving forward until they come back and see you again. I should say that the 24 milligrams is kind of like a de facto max dose, just because it's what most insurance covers. But we are doing clinical trials, and they're here at UNM now, and there is evidence to suggest that even 32 may be beneficial and optimal for people that are using high doses of fentanyl in order to stabilize them appropriately. I have been putting prior authorizations through for people to be on 32 who are failing at 24. Failing is kind of like a pejorative term. I would rephrase that, but who are still having cravings or withdrawals are still using at 24. So, and then again, in red at the bottom, the goal is to get the patient up to 24 on the first day, if that's what they need. Patients typically stabilize out on at least 16, if not 24, if not 32. So in order to prepare the patient for that withdrawal period, typically that, as I mentioned, that 12 to 24 hours, in order to maximize their success, to get them through that and to make them comfortable during that period, there are some medications that I prescribe that can be very helpful. I typically almost always prescribe the following two medications, and that's clonidine at 0.2. You can do 0.1, but I think 0.2 is more aggressive. Clonidine 0.2 twice a day. And that medicine is an alpha antagonist, meaning it dampens the sympathetic overdrive that's characteristic of opioid withdrawal. That fight or flight response that makes people very uncomfortable. You can kind of think of the opioid itself as if you think of the patient's brain as like a beach ball and you're standing in a pool of water. The opioid pushes the brain down under the water, right? Because it's a CNS depressant. And then when you remove the opioid, suddenly the beach ball or the patient's brain shoots up out of the water. And that's very unpleasant. And, clonidine, for that reason, is the mainstay of opioid withdrawal management. The other medicine that I almost always prescribe is methocarbamol, which is a muscle relaxer, and really helps people with myalgias or restlessness and that kind of thing, and that feeling of kind of like crawling out of their own skin. And then also optional medicines that you can discuss with the patient depending on what bothers them the most about their withdrawal syndrome. NSAIDs just for, muscle aches, et cetera, loperamide for diarrhea, trazodone potentially for sleep, and Zofran for nausea. And you want to give the patient a really good pep talk going into this. Remind them of the goal of the buprenorphine. Again, it's going to help allow them to focus on other priorities in their life. Typically people who are coming to you to initiate Suboxone are sick and tired of the psychosocial disarray that their opioid use disorder has caused. So really, emphasize that. You can also explain the concept of sort of receptor competition, meaning that the fentanyl and the buprenorphine are going to be competing at that receptor site. And if for some reason they're feeling discomfort when they initiate the buprenorphine, they encourage them not to give up, because they want to be aggressive and not necessarily literally double down, but figuratively double down on the buprenorphine, so that they're introducing more and more buprenorphine to outcompete the fentanyl, and eventually they'll start to feel better. But you may have to prepare them mentally and psychologically for a little bit of a battle in their brain. And you can also, if you have, and I've done this up in Espanola, which was very helpful. If you have, we were kind of unique because we were part of a harm reduction agency that had a lot of staff with lived experience starting buprenorphine. But if you do have a peer support person, or you have someone with lived experience who's initiated Suboxone, you can connect the patient with them, and so that they can give them some encouragement and explain what the experience might be like, and so they have some anticipatory guidance on that. And then just generally speaking, at ASAP down here in Albuquerque, we estimate that 70 to 80% of our patients with opioid use disorder have PTSD, and if not, then they typically have another concurrent mental health disorder. But I really just wanted to emphasize the expert consensus, which is that concurrent mental health disorders need to be identified, diagnosed, and treated aggressively, because most people are self-medicating with opioids in the first place, the symptoms of these concurrent mental health disorders. If you think about someone who has been abused as a child, they have PTSD, they struggle with anhedonia or a difficulty experiencing positive emotions, they're hypervigilant, they have hyperarousal, they're on edge all the time, waiting for something totally bad to happen. And the opioids, delete those negative symptoms for people. And as long as they're having these symptoms and they're used to having the opioids erase them, they're still going to have that urge to self-medicate an uncontrolled PTSD, for example, with fentanyl, what have you. So I really, especially PTSD, screen very aggressively and treat it very aggressively, so that they don't become kind of like a problem moving forward that people need to, again, continue to self-medicate. Just as a brief refresher, SSRIs are the first line medication treatment for PTSD, in conjunction with the other first line treatment, which is trauma-focused therapy with a counselor or psychologist. And I recommend that they do both. Prazosin or clonidine, very helpful for nightmares. And if they're tolerating a good dose of an alpha antagonist like that at night, you can move baby doses to the day in order to mitigate hyperarousal and hypervigilance, which can be very helpful for people. And then I've also had good success with relatively low doses of an antipsychotic for those people that have PTSD and are very hyperreactive, irritable. They have rage, anger outbursts, affective instability. I typically like Abilify because it has a low index of side effects, and or Latuda, which requires a PA, but it's technically metabolically neutral, or at least theoretically, and so you wouldn't expect people to have weight gain, which can be a big problem with other antipsychotics. That's kind of what I wanted to go over today. And with that, again, thank you very much for having me. It was a pleasure chatting with you, and I'll open it up to questions.